Hello and welcome to Pennsylvania Crossfire. I'm Buddy Lesevoy, a local attorney, and I'll be your moderator today. Pennsylvania Crossfire is brought to you by this station and our sponsors to air important issues of the day. Today, we're pleased to have three guests with us. First, I'd like to introduce on the left Dr. Stephen Hunt. He's an MD and PhD, an interventional radiologist and basic science researcher at the University of Pennsylvania with an interest in economics and politics. On the right, we've got Dr. Nirav Mehta, and he's also an MD with an MS degree. He's a radiologist at Mainline Health and has an interest in economics and healthcare management. And finally, we're pleased to have back with us Dr. Saurabh Jha, better known as Harry. He's an MD with an MS as well and a radiologist at the University of Pennsylvania with an interest in economics, policy, and value. Today, we want to discuss the VA scandal. It's been dominating the news of late and for several months, and I'd like to start with Dr. Hunt by asking you, if you would please give our viewers a little background on this scandal.
Sure. Well, Buddy, what's been in the news is essentially an attempt by some of the folks at the VA, administrators namely, to cheat the system that's been put in place to measure metrics. And the metric that we're actually trying to measure here is how fast patients are actually able to get access to their doctor and how long they wait for procedures and things like that. So we all can agree upon the idea that our veterans really should come first in line when it comes to health care. In fact, if you go back to the Plymouth colonies before we ever had the United States of America, one of the things they established was that anybody who fought in the Indian Wars had their disability covered. You fast forward a few years to the Revolutionary War, it was one of the major ways in which they got folks to fight for our freedom of our country and independence was to promise them health care afterwards. A little bit after that, we had our first federal health hospital, which was in 1811. Fast forward after the Civil War, major expansion of benefits for veterans, and then to the 1930s under President Hoover, the establishment of the sort of modern-day Veterans Administration. Finally, under the senior President Bush, we came in 1989 with the consolidation of it being a cabinet-level position. As President Bush said at the time, there's no place better than they should be than at the seat at the cabinet in the Oval Office with the President of the United States of America. Since that time, we've always had a seat at the table with the President in terms of the veterans of the United States of America. I work in a veterans hospital. It's very much my pleasure to serve those folks. And what's happened really is that the current President brought in General Shinseki, a very able administrator, to modernize the modern VA, to make it really responsive to the veterans and to make the bureaucracy be less apparent and the actual medical care be what's at the center. And I can tell you, working in the VA, there has been dramatic improvement in the health care. Unfortunately, by putting these metrics in place of measurement, what we've ended up with is folks cheating on the exam. Now that they know what they're being measured on, they want to go out there and cheat. Now, you're going to hear from a lot of the folks here about different policy prescriptions or why there's this nation of cheating, but that's really what it comes down to. You made a test, and the folks are out there cheating.
Dr. Mehta, what do you think? Why did the scandal occur?
Well, Buddy, I liken the situation to a teacher in a classroom. You've got a teacher whose salary, career advancement, bonuses is really dependent upon the grade that they give them on the math test. So you have a bunch of students, they take a math test, and let's say you got a range of A's, B's, C's, D's. Well, the teacher gets a bonus if she can make all of those into A's. And they did that. So all of a sudden, you've got a classroom where the teacher has changed all those grades to A's so that they can actually advance in their salary and in their career. It's a problem of incentives. It's a problem that the VA is not really subject to any market forces, and really doesn't have a whole lot of reason to really keep those kids in that classroom. If you're buying a car, let's say you're a veteran and there's a veteran car dealership, and you go to this car dealership and say, okay, I want a car. Now the owner of that dealership will say, well, fine. I will tell you that this car is fantastic. I give this car great reviews. And by the way, I get a bonus and advancement by telling you this, by saying that this quality is fantastic. Well, that's a problem, especially when you as a veteran don't have the ability to go to another dealership to buy another car. So I really do believe that a system like a voucher system, where a veteran would have a voucher, be able to go into a private hospital or an academic hospital and choose where they want to get their care from is something that will actually force the VA to become more responsive to the ultimate patient, the veteran.
So use the vouchers as a way for the consumer to become the judge and jury, if you will, of who's providing the best service and providing the best value, best timing, etc.
Absolutely.
So, Dr. Jha, I'd like your perspective. I've heard a lot of references to now claims that our system is becoming more and more like the British healthcare system. What's your perspective on that?
Well, buddy, that's a very interesting comparison, because when I came to the United States a few years ago, I did a lot of rotations at the Veterans Hospital, and it reminded me a lot of the NHS in good ways, and also some of the structural problems one inevitably has from that. But before I go into that, I think it's interesting, Dr. Hunt has not mentioned that the gaming of the system resulted in several people forfeiting their lives in wait of the appointments. And I think that's important to remember, because you know, when you're dealing with statistics, you're not dealing with you know, mean and p-values. You're dealing with actually real people. And the thing about these real people, what I came to the conclusion at my time at the VA, was that they are absolutely salt of the earth people. I mean, these guys have gone, they've fought for us. We sleep because they've put their lives in danger. The one thing they don't do is really care a lot about their medical health. I don't mean that in a bad way. I mean that in a way that they value their lives so much that they live every day. They don't fret about cholesterol. They don't fret about blood pressure. You can say that they live life for the moment. And that, in my opinion, has resulted in a level of utilization at the VA that is far lower than had those veterans really been as complaining, as high utilizers of medical service as the rest of the population were.
So clearly they're not the abusers, like us normal mortal types that are, you know, constantly begging for every you know, level of examination humanly possible. So they're truly underutilizing. Priorities in life are, you know, country, duty, service, and neglecting themselves.
Right, and they are actually the unworried unwell. So the laissez-faire people that actually harbour a lot of disease, and they suffer from it. And what that actually has resulted in is that you've got a system that has limited resources, or limited resources have been put forward to it, which has been able to sustain itself through an element of underutilization. And what you see right now is that the tide has broken, the river bank has been broken. I mean, we've come to the reality that there has been investment in the VA, just as there has been underinvestment in the NHS structurally, in comparison to what the population needs, what the population wants, and what the technology is there, and that's a paradox. So how do you deal with a paradox? That's the key question. And I think that the metrics, what that's done is that's created a pseudo control of the situation, and it's absolutely similar to the NHS in that regard.
Interesting. So we've got underutilization of the population that probably needs it the most, and now it's catching up a little bit and taxing the system. Let's take a break so we can hear from our sponsors. We're coming right back with more on this topic. Please stay tuned. Welcome back to Pennsylvania Crossfire. Today we're discussing the VA scandal, and we're pleased to have three distinguished doctors from the Philadelphia metro area. We left off, I cut you off a little bit there, Dr. Jha. You were talking about the comparison between NHS and the VA system, and other than recognizing the fact that our veterans are generally not taking the best care of themselves and prioritizing a lot of other important things for the rest of us, not necessarily for themselves, and to the contrary, to their own potential demise. Now that's being exacerbated. The system was cheating them and compromising their health and their true needs. Now we're seeing some capacity issues and disparity between, utilization from historical perspectives. What other comparisons would you make to the NHS?
So interestingly, in the NHS, a couple of years ago, perhaps, I don't remember the exact date, there was a scandal in Mid-Staffordshire Trust Hospital where there was a lot of low morale and a lot of quality and safety issues. Of course, the VA doesn't have that. The VA physicians are excellent, and the morale actually amongst physicians and the staff pretty good. But there is one element of similarity between the two. So what happened in the Mid-Staffordshire Hospital was that the government wanted incentivized administrators to meet certain targets. One of them was the target of actually getting a patient seen through the emergency department. You cannot exceed a certain time, let's say, for instance, 2 hours or 4 hours. And that target was demanded, or rather incentivized, without any capacity increases. And so what happens when you try and expand a balloon that doesn't want to expand, it sort of goes in different directions. So what direction did it go? So what happened was that a lot of patients were shuttled into the corridors, and I literally mean corridors. Their beds were in the corridors, waiting for beds in the wards on the floors to open, just so that the emergency department could meet its targets. And so what you have over here, you have a target culture, an ambitious target culture. Let alone the fact that that was misused, but even if that wasn't misused, you have a target culture without accompanying infrastructure for a population that should get more medical care than they do. And what we're really, I think the message I'm getting from all of this is that there is terrible underinvestment in the Veterans Hospital. And really that's the most striking parallel with the National Health Service. And what that does, really, it allows people to make a claim that we're delivering such great care at such low costs. But the reality is that the costs are not fully appreciated.
So what kind of solutions? Clearly you've alluded to money, and Dr. Mehta, you've alluded to vouchers. What are the solutions here? Do you have any suggestions?
Well, I definitely think that we have not taken into full account the cost of war. And the cost of war includes the cost really of taking care of these veterans when they get home, first and foremost. And instead what I hear a lot of in Washington is acting as if this is simply, now that it's a cabinet level position, simply a part of the budget that can be cut along with everything else. Let's cut 20% off the top of everything, and they'll just include the VA in that as well. I think that on the other side, and that serves the political interest who want to discount the cost of war, which is quite expensive, and particularly caring for our veterans. I think that this is, for the most part, though, tempest in a teacup. What I've seen over the last 10 years, and what I think, if you look at the history of the VA, is only an improvement gradually over time of care for our veterans, and went from really a poorhouse system back when it first started, of folks living in a poorhouse and the government having to step in and help care for them, to now our veterans have a very top-notch, high-quality healthcare system in place. Many people would be quite happy with receiving that system themselves. So I disagree with Harry that it's just because they're veterans that they like the system. I know coming out of my program in interventional radiology, which is one of the very competitive disciplines, everybody wanted a job at the VA. With the VA, you have your interest as a physician aligned with the patient. You're not out there to gouge them for money because you don't get any more money. You're on a salary, okay? So your interests are better aligned with the patient, and this is the way the Kaiser system is after the war. When Kaiser sat down and decided for his folks building ships that he wanted them to be in this system of a maintenance organization, that's the way it worked too. Again, you had the alignment of a system with the needs of the patient, and not, let's see how much money we can gouge out of these people, let's see how many tests we can run and how many surgeries we can perform, and we're going to get paid for all of it. So instead at the VA, yes, there's not the incentive of money. So I'm not incentivized when I go to work at the VA to get up every morning and go gouge these folks for money. But that's not why I became a doctor, and I think you'll find that that's not why folks become doctors in the first place. They get out there because they want to help people. Otherwise, they would have gone into business or some other field if they wanted to make money. You don't make money in medicine. So the lack of money, or somehow the lack of the free market, is leading to worse care for our veterans. It's just simply not true. If you look at the RAND study, which was done completely independently, and you couldn't cheat on that exam, okay, because these folks sent their own people to go out there and interview patients. What they found in the RAND Corporation survey of veterans was these approval ratings that you would, any independent agency and every independent hospital would love to have, okay? Because folks in general are pretty happy with their care, and their access to their doctor is pretty good. There are these constrained systems, and you do have bad apples. But you then, when you have an example of a teacher cheating on the test, you say, okay, kids, here's a voucher. Go off to the next school and get your education instead. That just seems ridiculous. No, get rid of the bad teachers. If it's a matter of education of the middle management workforce in the VA, then that's what it needs to be. I think it's a travesty that General Shinseki was forced to give up his job, because what he has done is oversee a very positive direction of healthcare at the VA. But instead, he got caught up by this fact that folks are cheating.
So, just to be clear, your position is it's not a matter of money, and the incentive reference that Dr. Mehta was talking about, was that at the administrative level? Because it clearly sounds like, at least culturally, it's not the physician level. They're not incentivized for
absolutely.
For
there's no incentive for the doc to somehow that they're cheating on the system. They had nothing to do with it. You don't see anyone talking about the doctors there. You're talking about administrators who wanted to show that their hospital was performing a little better than the other 152 VA hospitals around the nation, okay? And I don't even know if there was a financial incentive there, to be honest with you, whether they were financially incentivized or if it was simply a matter of pride to show that they had the best turnaround times. Whatever it was, you made a metric, and some people, if they're not of great moral fiber, are going to cheat.
So your answer is clean house, laser focused on the problem, the few bad apples, and that it's not a systemic problem throughout, at least in your experience.
That is my experience.
So, Dr. Mehta, you're a proponent of the voucher system.
I am. I mean, I think the Veterans Hospital does try to provide high quality care. But hey, listen, even with all the fixes and all the things that they do, let's let them compete. Let's put money into the hands of the veterans and let them choose. That's the final litmus test. How happy are the veterans with their quality and access of care? I mean, there may be a RAND study out there that has surveyed a bunch of veterans, as Dr. Jha said, that don't complain, that really put their own selves below country and people. I would love to have a customer base like that. They're not going to complain about my service. Give them choice. Why limit their choice? That's all I'm saying. And let the market decide. Let's see if the fixes, and let's see if retraining managers and supervisors and coming up with new incentive programs, let's see if that works. How do you know if it works unless you give veterans a choice?
Well, I want to go back to you, Dr. Hunt. Is there a downside to the voucher?
Yeah. So, for example, I work at the University of Pennsylvania flagship hospital called the Hospital of the University of Pennsylvania. We get folks over from the VA where they can't get a procedure done over there. Guess what? Those people are charged about 3 times the money that somebody walking in off the door is. Why? Because the VA system is set up such that it pays whatever is required for their veterans. So you think healthcare is expensive now? Well, wait till these folks are walking out with their voucher and they're not able to get what they want to pay for because they're being gouged in the private marketplace with all these things. You see, this is, to me, it's always this, the notion of vouchers and things like that are kind of a proxy for undoing this great system we've built.
All right, let's hold on that thought so we can take a break to hear from our sponsors that make the show possible. Please stay tuned. We're coming right back. Welcome back to Pennsylvania Crossfire. Today we're discussing the vouchers. I want to talk about vouchers involved with the VA scandal and see whether vouchers might be a viable part of the solution. Again, I ended up cutting another doctor off, and let me also remind our viewers we're privileged to have 3 distinguished doctors from Philadelphia, all with a tie to radiology, as it turns out. But Dr. Hunt, I cut you off, and you were explaining your position on why the vouchers would be counterproductive in the use here and ultimately would lead to escalating costs. So on that point, I want to just ask and ask all 3 of you, is there a way to have a voucher based on the procedure rather than potentially a dollar volume? This way, you know, the voucher is good for the procedure and should be taken anywhere that a patient, in this case, or a veteran, needs to have it done. If the VA is backed up, if they can't get in for too long, they can take the voucher across the street to the, you know, hospital of the University of Pennsylvania.
In essence, they have that system now. So they come over, they need a special procedure that isn't performed at the VA, they come over for that procedure. But what I'm telling you is that the amount of money that's paid is going to be charged differently based on their voucher. So they hand them, they say, take out my gallbladder. They call that a cholecystectomy. Well, they get charged $800 instead of $200 if I was someone who was an insured patient walking in with private insurance, because there is no bargaining in that sense for those medical care, because it's not really a free market. Okay. And then the other thing I would say is, I just want to answer Dr. Jha's claim, because he wanted to talk about the deaths associated with waiting lists. I don't know what those number of deaths is, but I assume any loss of veterans' lives is catastrophic. What I will say is this: 45,000 Americans, in the largest study that's been done to date, die from a lack of insurance. And if you start compromising the access of the veterans to their system, or in some way making it confusing for them of how to navigate the health system that they know, and start sending them willy-nilly off in different directions, they're going to be part of that 45,000. Right now, the reason why they're not is because they have access to medical care if they need it. But you start taking away their insurance, or in some way breaking it down, you make that house of cards fall. Now you're going to have a lot more than 45,000 folks, because these are folks who cannot afford to get out there, many of them, and buy insurance in the private market. And
we already know they're generally inclined not to take care of themselves.
Absolutely.
So, Dr. Jha, how about your thoughts for solutions?
Well, the first thing I think that needs to be clarified is Dr. Hunt has come up with quite a few straw man arguments, which is rather typical of him if you knew him personally. The first thing he's done is he's actually equated physicians at the VA with the administrators, and that's wrong. Of course the physicians are dedicated, and that's the greater tragedy of the whole event, is that you have people that are so removed from the patients who are making critical decisions, if not in kind and in numbers, who interpose themselves between them. So simply saying that, you know, the VA has great physicians, and they do, and being a physician of the VA reduces some of the incentives associated with fee-for-service, which it doesn't in any way mitigate the problems associated with having administrators incentivized for targets that can be manipulated in a closed system. So back to that closed system. I think that vouchers possibly could work. I don't necessarily agree that it's the magic bullet. I don't think that the government would be so helpless that if there were vouchers, they would be gouged. After all, it is the government, and the VA is allowed to price negotiate. The CMS isn't, but the VA is. That's an important distinction between the two. But again, I'm going to go back to the main thing over here, which is that let's ask ourselves not only why has there been an administrative gaming, but what is this being built on? Has this been built on sand, or has this been built on rock? Well, you know, that's a false dichotomy. But I would say that somewhere down the line, when you look at how the rest of the U.S. healthcare has expanded, you look at how healthcare in Germany, in France, in England, even in Australia is increasing, you have to ask yourself, why has the VA cost not gone up as dramatically? And if the answer is we're doing a great job, then I think you have to, again, introspect and say, well, maybe that's the answer, but maybe there's another answer. And what we've seen over here is that with the use of metrics, with the use of electronic medical records, which has certainly integrated care in some ways, you can dramatically hide suboptimal care simply because they are very statistically difficult to pick up. And that's just the nature of measurement. So I would say that the most important thing we need to do over here is come and sit down at the table, be absolutely honest about the cost, absolutely be honest about the structure of the VA, the trade-offs that occur between any form of quality and access. I mean, you can have great doctors, but you know, they can only be working from 8 till 6 or 7. If there are not that many of them to take care of the demand, then...
Would that we could all go in at 8, Harry? Speak for yourself.
Or 7 for that matter. Dedicated doctors like Dr. Hunt get in there at 6. But
More like
you still have a resource issue. And that, until you sit down and be honest about that, I don't think any solution of the VA, be it voucher or be it just, it's all right. Well, basically, I don't agree with Dr. Hunt's, it's all right, Jack. That's what I want to say. It's not.
So it's not all right, it's not vouchers.
And I have to say something about cost. And fine, if it costs a veteran $800 to get their gallbladder removed at the Hospital University of Pennsylvania versus $200 at the VA, these are people who went and fought for our country, put their lives and their health at risk. I'm happy paying that bill if they're not getting access to that service at the VA hospital.
Absolutely, so am I. All I'm saying is your shifting of it to the voucher system is going to end up costing more money. And I'm fine with that if we get better outcomes. What we do know is with the electronic healthcare system, medical record system there, we're able to look at those numbers very closely.
Unfortunately, that's all the time we have for today. I want to take this opportunity to thank our panel of experts and doctors from Philadelphia, Dr. Hunt, Dr. Mehta, Dr. Jha, and I want to thank our viewers at home for watching. Please be sure to tune in next week for another great edition of Pennsylvania Crossfire. This is Buddy Lesevoy for Pennsylvania Crossfire, hoping you have a fantastic week.